Hi everyone, and welcome to the last set of slides that we're going to have in regards to muscles for the axial body. This will end the set of muscles for the semester, and after this we will be moving to physiology for the second half of the semester. As you can see by this slide set, this is the muscles of the thorax and abdomen. We've already done all the muscles related mostly to the spine. Here we're going to be talking a little more about those muscles involved with the rib cage and those of the abdomen. So the first one we're going to talk about is something called serratus posterior superior. This muscle tells us a number of things. First, it tells us the shape, and the second, where we find it. Whenever you see the term serratus actually represents a muscle that looks like the teeth of a saw. So like a serrated knife or a serrated blade. So it has these sharp points that come together in a sort of a pattern. The next part tells you that it's in the posterior aspect of the thorax, and the third tells you that it's in the superior aspect of the posterior part of the thorax. So its attachments start at the lower portion of the ligamentum nuchae and the spinous processes of C7 to T3 to the superior borders of the ribs 2 to 5 on the external surface. This is basically a respiration muscle. It's used when we take in a deep breath. So its function is to elevate the ribs 2 through 5 at the sternocostal and costospinal joints. So this muscle actually lifts the ribs up, the upper ribs up. And if you remember from the demonstration in class, we have the bucket handle movement in the superior aspect. So this would represent a muscle that would help in the bucket handle movement of the rib cage. Its innervation is the intercostal nerves 2 through 5. We see it here in the diagram, how it's part of the nuchal ligament here, and it comes down and touches on these sort of a downward oblique angle from medial to lateral. Now you can understand why it pulls the ribs up on inspiration. The next one is serratus posterior inferior. Same idea, has a serrated type of quality to it on the posterior aspect, but instead of the superior part of the rib cage, it is in fact on the inferior part of the rib cage. So its attachments are the spinous processes of T11 to L2, T11 to L2, and you can see that it is lower than the superior aspect attachment of serratus posterior superior. So the spinous processes of T11 to L2 to the inferior borders and external surfaces of ribs 8 to 12 near their angles. Its role is to pull the ribs down on inspiration. So if we think of serratus posterior superior lifting the ribs up and serratus posterior inferior pulling the ribs down, we can see now how this increases the diameter or the size of the rib cage when we're attempting to take a forced inspiration. In other words, remember Boyle's law, we are making the container larger, therefore we are allowing more gas to enter into the lungs. So therefore the functions of serratus posterior inferior is to depress the ribs 9 through 12 at the sternocostal and costospinal joints. Its innervation is the subcostal nerve and the intercostal nerves that we find in 9 through 11. So remember, the intercostal nerves actually travel between the ribs. That's what intercostal means. So 9 through 11, this muscle is innervated along with the intercostal muscles. This muscle is also innervated by those nerves. You see it here. Here is the serratus pattern, the sawtooth type of pattern. And we see again, we have the central attachment. And instead of obliquely traveling inferior, these guys actually obliquely travel superior, and their whole role is to pull the ribs down, again, to increase the container. So I sort of alluded to that when I was talking about the intercostal nerves. We have a set of muscles, and I did talk about to some degree about this in class last week when we were looking at the groove on the inside portion of the ribs. And I told you that a nerve and a vein and an artery travel through there. Well, we're going to discover that these intercostal nerves that I speak of in this groove in the rib is actually the nerves that innervate these external intercostals, and the next group, the internal intercostals. So they're exactly what they are. Say this one is external, and it is in between each pair of ribs and we'll find out what its role is in a moment. So its superior attachment is the inferior border of one rib to the inferior attachment being the superior border of the rib directly inferior. So I'll repeat, it arises from the inferior border of one rib to the superior border of the rib directly inferior. Its function is to elevate the ribs 2 through 12 at the sternocostal and costospinal joints, which is its primary action. So it makes sense. If the muscle is reaching down from a superior rib to the superior surface of an inferior rib, you can understand how it helps pull the rib up. Its second primary role, it does help to some degree with contralateral rotation of the trunk at the spinal joints. Its secondary movements helps flex the trunk at the spinal joints. Remember, being secondary, they're not major movers by any means. They do help to some degree extend the trunk of the spinal joints, and they also, to some degree, help laterally flex the trunk of the spinal joints. And as I sort of alluded to when I first started talking about this muscle, its innervation is the intercostal nerves at each level. So that would mean the intercostal nerve at 2, 3, 4, 5, 6, 7, and so forth, all the way to the 12. So we see here the external intercostals are here on the outer portions, and remembering arising from the superior surface arising from the inferior surface of the superior rib down to the superior surface of the rib directly inferior to it, sort of on the outside part of the rib. The next is its brother, which is the internal intercostal. So this means this is more internal as compared to the external. So think of the external intercostal being what faces out by the skin. The internal intercostal lies deep to the external. Its attachments are the superior border and costal cartilage of one rib to the inferior border of the rib and its costal cartilage directly superior. So to remember, the external intercostals arise from the inferior border of a superior rib down to the superior border of an inferior rib, whereas internal intercostals arise from the superior border of the inferior rib to the inferior border of the superior rib. Therefore, instead of raising the ribs, or we can say that where the external intercostals lift the inferior rib, the internal intercostals depress the superior rib. So its functions, the primaries are, it depresses ribs 1 through 7 at the sternocostal and costospinal joints, and its other primary role is ipsilateral rotation of the trunk at the spinal joints. The secondary movements are minorly flexing the trunk of the spinal joints, extending the trunk of the spinal joints, and minimally laterally flexing the trunk of the spinal joints. And these muscles are innervated by the intercostal nerves, the same as external, at each level. So we see here again in the same diagram, our external intercostals are here at the external parts at the front. Deep to that is the internal intercostals, and you can see how it's lifting the rib up from here to here in the external group, and from here to here it is pulling the rib down. Another minor muscle is, or not minor, but it does some work within the rib cage, is something called transversus thoracis. Should probably give you a pretty good idea of the direction that this muscle travels. Its attachment is the inferior 2/3 of the internal surface of the sternum, internal surface, not the external, the xiphoid process, and the costal cartilages of ribs 4 through 6. I'll repeat, inferior 2/3 of the internal surface of the sternum, the xiphoid process, and the costal cartilages of ribs 4 through 7, to, again, the internal surfaces of the costal cartilages 2 through 6. This muscle's role is to depress the ribs 2 through 6 at the sternocostal and spinal costal joints. So a lot of these muscles that we're talking about here today, at this point, do play a role in respiration. When we look at respiratory muscles, the major respiratory muscle is the diaphragm, and we will be discussing that shortly. So it is the muscle, the diaphragm is the muscle that we utilize when we are relaxed breathing. When we have to breathe in deeply and breathe out deeply, which is considered active breathing, these are the type of muscles that are involved when we are trying to have those excessive movements, again, making the container either larger or smaller. So the function of transversus thoracis is to depress the ribs 2 through 6 at the sternocostal and spinocostal joints. And again, like the others, its innervation is the intercostal nerves at each level. So we can see it here. This is a posterior view of the sternum, manubrium, and 1 through 6 ribs. We can see how this muscle radiates out from the posterior surface of the sternum to find attachment on the ribs superiorly. And you can understand now how this depresses the ribs if the one attachment is going to move to the next. So I just spoke about the diaphragm being used in passive breathing, and we're just going to spend a bit of time on that now. So the diaphragm is considered to be a domed shaped muscle. In other words, the central aspect of this muscle rises superiorly. It does separate the abdominal and thoracic cavities, so it is considered the border. So superior to it is considered the thoracic cavity, and inferior to it is considered to be the abdominal cavity. It is the chief muscle of inspiration, although I suggested that it tends to be the only muscle that works when we are relaxed breathing. What's interesting is the pericardium of the heart lies on the central part of the diaphragm, separating it into right and left domes, normally with the right higher than the left. And I'll ask you for a moment to think of why that is. And of course, the reason being is because the heart lies on the left, or reflects to the left. What you need to realize is that the diaphragm actually does, on its some of its fascial parts, does share some fascia of the heart itself. So the heart is somewhat attached to the diaphragm through fascial attachments. So that's why we can say that ultimately the heart sort of really does lie on top of the diaphragm. Now, during expiration, which is breathing out, the right dome reaches as high as the 5th rib and the left dome to the 5th intercostal space. So what I would like you to try and attempt to do is, using the sternal angle of the manubrium and the sternal body, come across to the 2nd rib and count down 2, being at the angle there, 3, 4, 5, 3 down. And you might be quite shocked as to how high up this diaphragmatic dome actually does reach when we're expiring, when we're blowing out. In most cases, most people don't realize just how high this diaphragm goes. We generally tend to think of the lungs filling out the entire rib cage from top to bottom, when in fact it actually does not. Now, within the diaphragm, because it is a border between the superior thoracic cavity and the inferior abdominal cavity, there are a number of structures that do pass from one cavity to the other. So we have the aorta, which arises from the heart and travels on the posterior aspect of the thoracic cavity down to feed the lower limbs. It has to pass through this border, and it does so through an area of the diaphragm called the aortic hiatus, which of course allows the aorta to pass through. Last thing we want to do is be pinching this vessel off. So it's a relatively large hole that arises from the way the diaphragm attaches at the vertebral bodies. The second thing that passes through the diaphragm is the esophagus, which is the tube that runs from the back of the mouth all the way down to the stomach. So when we're eating, this is the tube that takes food material or chewed material down to the stomach for digestion. So it passes at a point called the esophageal hiatus. So this is a hole that allows food to pass through. Just as a sidebar, because I will be discussing this in the A&P class, it is this passage through the diaphragmatic muscle tissue that creates a sphincter that prevents food material from exiting back out of the stomach into the esophagus after we eat and swallow our food. The third structure that must pass through is blood returning from the lower part of the body and the lower limbs back to the heart. Remember, the heart sits on top of the diaphragm, so blood returning has to pass through the diaphragm to get to the heart. And it does so via a very large vein that passes through here. Now, what passes through here is the vena cava, and the hole that it passes through is called the caval foramen. In other words, the hole for the cava, or the vena cava. So we see here just how high this muscle actually rises, and we can see this dome-shaped configuration that the diaphragm is on expiration. So we're going to learn that when the diaphragm contracts, it actually pulls down. So when we're breathing out is when the diaphragm is at its most relaxed and as the highest it goes. You'll note here in this diagram on the right, we can see how the heart lies on top of the diaphragm, and so to some degree do the lungs on the lateral aspects of the diaphragm as well. This is an inferior view looking up at the bottom of the diaphragm, or the inferior surface, and we can see the three holes that allow for structures to pass through. Here in this area is the esophageal hiatus. This is where the esophagus travels through the diaphragm to enter into the stomach, bringing with it material that we have chewed for digestion. Here is the caval foramen, which is the hole that allows the vena cava to pass up through to get to the heart, bringing unoxygenated blood with high amounts of CO2 back to the heart. And then here on the most posterior aspect, we can see a relatively large space. Remember, I talked about how the diaphragm finds its attachment either side of the vertebral bodies, which gives us this natural formed space, this hiatus, which allows the aorta to pass through as it's traveling down to feed structures below the diaphragm all the way down to and including the lower limbs. So its attachments then are a bit different, because if we go back again a slide, we'll note that there are attachments on the peripheral aspects of the diaphragm, but if the heart is sitting on the central aspects as well as the lungs, then we know for sure that there's really no bony attachment at the central aspects of the diaphragm. So the muscular part of the diaphragm lies peripherally, and the fibers converge to what's called a central tendon. There is no bony attachment to this tendon. It is an actual very broad sort of area at what will become the sort of the apex almost of the diaphragm when we're breathing out. Anatomically, the central tendon is divided into three leaves. So therefore, within the three leaves, the muscular sheet of the diaphragm then is divided into three parts. So remember, we're thinking of, again, the diaphragm centrally is attached to this relatively large central tendon, remembering that the periphery of the diaphragm is where we find muscular attachment. So the three parts are, first, anteriorly the sternal part, which is two muscular slips that attach to what we know as the xiphoid process, that lower part of that process at the bottom of the sternum. The second is the costal parts, so this obviously costal meaning ribs. It attaches to the internal surfaces of the six costal cartilages and their ribs, helping us form the dome. And then the posterior aspect is the lumbar attachment. From L1 to L3, there are two aponeurotic arches. Remember, we saw in the picture there, I said on either side of the vertebral body, which gives us the aortic hiatus. So these two arches, these two separate sort of ligaments, are actually known as the medial and lateral arcuate ligaments. So the division which allows for the aortic hiatus then form the two medial and lateral arcuate ligaments. We have two tendons called the right and left crura, and the three superior lumbar vertebrae to the central dome of the diaphragm. So we see here where we have the two tendons. I'll go back again. We have the two tendons called the right and left crura, and then we have two aponeurotic arches. Now the aponeurotic arches are up here, and then we have the two ligaments here, and I called them the crura. In here they are called the crus, can mean the same thing, and we have them here. I apologize, I believe I said that these previously these two tendons were the aponeurotic arches. They are not. These are the aponeurotic arches here, and this is the two ligaments here, meaning that they are the right and left crura, and as I said, the crus here. And then from those peripheral attachments from the ribs and the xiphoid process here, it all meets medially at this very large central tendon structure here, which I said here helps form the dome of the diaphragm. We can also see it here in the diagram. This sort of shows the two tendinous attachments here on the vertebral bodies with the peripheral attachments. Here, of course, the costal cartilages have been removed, and so too has the sternum, so we can't see the attachment to the xiphoid process here anteriorly, but there would be attachments to the ribs all the way around, and then the vertebral bodies posteriorly. Its functions: when it's contracting, it descends and comes down, and it is only the central part of the diaphragm that contracts, in other words, that shortens and moves. It's not that it pulls the ribs in closer, it's that way the attachment goes, it pulls the diaphragm down. And in pulling the diaphragm down, it actually expands the container, or we say it increases the volume of the thoracic cavity via abdominal breathing. So in relaxation, when the dome is at its most superior aspect, the container is at its smallest. When the diaphragm contracts, it pulls inferiorly down, flattening it, thus making the container larger, which is what we need for inspiration for air to enter in. It has a number of innervations because of the vast size of it. The motor innervation is the phrenic nerves C3 to C5, so 3, 4, and 5. That means that nerves that feed this from the motor perspective arise from the levels between vertebra at C3, C4, and C5. I'll be talking more about that when we look at the relationship of nerves and muscles later in the semester. Sensory, so motor is contraction, sensory is sense or feel. Centrally is the phrenic nerve, C3 to C5. And when we look at the phrenic nerves, we do have one on either side. And this is can be a little bit unique, again, because of the vastness. I have seen patients in the past who had a surgical procedure done where unfortunately one side of the phrenic nerve was destroyed because of the procedure. So therefore only half the diaphragm really contracted, and these individuals really do find it difficult to breathe. So if the diaphragm isn't functioning properly, then all those muscles we spoke about earlier, they all have to come into play, even including, if we remember correctly, the scalenes also are involved here, and all these intercostals and so forth, because the diaphragm is unable to do the jobs it normally does. So that's the central parts, somewhat. Peripherally, on the attachment sites, this muscle is innervated by the intercostal nerves of T5 to T11 and the subcostal nerve at T12. So you can see that it's a very, very large innervation because it is a muscle that has a very large expanse. The next group I want to talk about are the abdominal muscles, which we find anteriorly. And there are 5 different sets of muscles we find in the abdominal wall. When we look down here at the Union Jack, the flag of England, what I want you to realize is I want you to think about the muscles, how they integrate, being very similar to this flag. So we have a muscle that travels superiorly, inferiorly. We have a muscle that travels transverse. And we have 2 sets of muscles that travel in oblique angles. And because of this configuration, it allows for a vast amount of movement and a lot of support. We have to remember that because the body has not utilized any bony structures on the anterior abdominal wall, something has to be in place to hold things where they are. The second part is we don't have anything on the back side of the spine other than muscle tissue. So if we think of all these organs and all these structures lying anterior to the spinal column, we need the abdominal muscles to somewhat help us maintain spinal health. One of the major things we used to think about was when people had back problems was we had to make these abdominal muscles as strong as possible, especially rectus abdominis, the one that would sort of lie right in the middle, going inferior superior. We now realized that over time that having the rectus group actually stronger than all the others actually made back pain worse because it was actually pulling things even more forward than we wanted to. Now what we look at is working the whole group, and working the whole group together, as well as some of the muscles involved in the back itself, has now evolved into what we think of as core work. So core work works all these together, making them all work towards providing a lot more support to the spine in its function. So this is one of the key things with this area, along with the muscles of the back. Like I said in class the other day, we always talk about stretching, when in fact sometimes issues are really not tight muscles at all that need to be stretched. It's far more about weak muscles. So I did talk a bit in class about loss of lordosis in the lumbar spine leading to spine problems, especially in the low back, and it absolutely does. The other thing we have to realize that if these muscles are also weak, it just sets the patient up for a potential of a back problem. And if we don't work on them and get the patient to get them strong, they will continue to have back problems because of it. So there are what are called 3 flat and 2 vertical muscles. The 3 flat muscles are the external oblique, the internal oblique, and the transverse abdominal. So obviously this gives you, when we look at the flag here, these are both on an oblique angle and external and internal in relationship to each other, and the transverse abdominal, which of course runs along the transverse plane. We do have 2 vertical muscles, one which you're all familiar with, the rectus abdominis, and one that is still out there. Some authors don't believe it exists, some authors do, but I do speak about it because of a potential with trigger points in it, and that is the rectus abdominis and a muscle called piridalis. So we can see here in the diagram, the famous 6-pack, which actually is not a 6-pack. If we truly want to make it anatomical, it's actually an 8-pack. We see here you've got from the top all the way down, when we find that this group all the way down to the pubic bone. We see it in both genders here. But what I want you to realize is that although we all think about this as the abdominals, it is in fact only one small part of a very large group that needs to work together for the body to function properly. Now, the thing to look at, if we think about the fact that I said there are, the 3 flats and the two verticals, all of these guys lay in particular tissue. They're all sort of buried one within each other. It has to be, because if we think about it, there's no bone in the front. It's very similar to the diaphragm. We do have bony attachments superiorly and inferiorly, which we'll find out, but ultimately centrally there's no bone for muscle to attach to. So what we say is that the 3 flat muscles attach anteriorly to a strong, large aponeurosis, which then attaches to something called the linea alba. In other words, the white line. Alba meaning white, linea meaning line. And this runs in a straight line, sort of dividing into equal right and left sides. The linea alba, along with the bilateral aponeuroses of the flat muscles, forms what's called the rectus sheath. It is this central rectus sheath that we find the 2 vertical muscles. So what I want you to understand is the flat muscles sort of go all the way around almost to the back, generally to the back. And as they come around to the central front, at the very center of that central front, where we find these guys, the flat muscles come together and they form an aponeurotic sheet that attaches to the linea alba, which is a central tendon that runs here. And this aponeurotic sheet that all comes together between the right and left sides of these flat muscles is where we find rectus abdominis embedded in it. So even though looking here and you see these lumps and bumps of the rectus group, they are in fact actually lying within connective tissue. So they're quite covered, and if you were to dissect here and remove the skin, you would still come across a fairly white silvery sheet that you would need to remove to further look at the actual muscle itself of the rectus group. So we see here in the diagram, we see the external oblique here, the internal oblique, and the transverse abdominis from a posterolateral perspective. Okay, we find here, remember the thoracolumbar fascia. We're going to find that there's some attachment there with these guys. But ultimately, I want you to understand that when we look at the external oblique here, you can see that it doesn't meet in the middle. We have some white material here. When we look at the internal oblique, same idea. We don't see it coming all the way to the center. We see it stopping here, again with some white material of that aponeurosis. Same with the transverse abdominis. We see again this white material, this connective tissue. So what we're saying is, if we compare right to left, if we were to remove the rectus group at the time being, we would see that in the very center would be a fairly significant piece of connective tissue, which is the aponeurosis created by the external, at the tips of, anterocentrally, the tips of the external oblique, the internal oblique, and the transverse abdominis. And we're saying that the vertical muscles here, that we see here, are actually buried within this connective tissue of this aponeurosis, with the very center area right here being a very thick tendinous tissue known as the linea alba. So again, I'll explain. We've got the external oblique here, the internal oblique, and the transverse abdominis. You can see they don't go all the way to the center. They all end laterally. On the anterior aspect, we then have this aponeurotic, this rectus sheath material here that would go all the way around to the other side where the twin, so this being the left external oblique, all the way around to the right external oblique. At the center would be this connective tissue here. We see it here. This is a lovely picture because this kind of shows you the rectus abdominis with some anterior aponeurotic material removed. So you can see it here with the white aponeurosis here. And again, just the central area is this aponeurotic tissue, with the very middle being a strong tendon, the linea alba. And remember that the rectus group actually is buried within this aponeurotic connective tissue. Seen quite nicely here. What I like about this picture is you can see how it layers. So the external oblique, the most exterior, the transverse abdominal being the next deepest, and then the external oblique, internal oblique being the deepest of all. All three of these, even though they're sort of bordered as though they're separate layers medially at the middle, they are not. All this connective tissue attaches. So all this connective tissue of here, here, and here all become part of the same connective tissue that we see here between the squares of rectus, and all attached to this tendon running from superior to inferior, known as the linea alba. And the nice thing about this picture, everything's kind of been deflected so we can see the rectus group not covered in this white aponeurotic material. But this is a lovely picture that shows you this whole relationship. And now you can understand why core work is so important for the back. With this variation of muscle direction, it provides an extreme amount of support if it's kept strong. So, the rectus sheath is an incomplete fibrous compartment. It is formed by the decussation, which means the division and interweaving of the aponeuroses of the flat abdominal muscles. Remembering the flats are external oblique, internal oblique, and transverse abdominis. So I'll repeat again, formed by the decussation, or the splitting or dividing, and the interweaving of the aponeuroses of the flat abdominal muscles, and the sheath has three layers. It is an anterior layer, which is the interlaced aponeurosis of the external oblique and anterior lamina of the internal oblique aponeurosis. It has a posterior layer, which is the fused posterior lamina of the internal oblique and the transverse abdominal aponeurosis. And then it has something called the crescentic line, or the arcuate line, which is a division or demarcation between the superior 3/4 of the posterior wall of the sheath and the inferior 1/4. Although anatomically these have been separated, do understand that when we say here, it's interlaced and fused, it's sort of all comes together in the dynamic human as providing a very strong connective tissue layer, which plays two roles. Obviously holds all these muscles together so that they're functioning properly. Also applies a massive amount of support to the anterior part of the body in the abdominal area. So here we are here. Here is the arcuate line here. We see, okay, this line right here. And we see here how these all interrelate. And we can see here is the external intercostal, or the external oblique, providing some fibers here anteriorly up in front of rectus. We can see the internal oblique providing both fibers that travel anteriorly to the rectus and posteriorly to the rectus. And we see the transversus is supplying fibers interlaced, basically supplying the majority of the posterior, or the area behind the rectus group. And of course, your linea alba is here in the center. Okay. Don't get too caught up in below and above the arcuate line. I'm not too worried about that. What I'm more worried about is your understanding of the relationship of the flat muscles here in the creation of the rectus sheath that the rectus group sits in. We see it again here again in this diagram. So let's talk about their attachments. The external oblique, meaning the most external of the abdominal group, arises from the anterior iliac crest, the pubic bone, and the abdominal aponeurosis to the inferior borders of ribs 5 through 12. So it's quite a large, expansive muscle on the lateral aspects. Remember, not centrally because that's rectus, more sort of a little bit anteriorly and certainly laterally. Okay, so the anterior iliac crest, pubic bone, and the abdominal aponeurosis to the inferior borders of ribs 5 through 12. Its three primary functions: it flexes the trunk at the spinal joints, it laterally flexes the trunk at the spinal joints, and it contralaterally rotates the trunk at the spinal joints. Its a secondary role, it does help compress the abdominal pelvic cavity, and it does to some degree depress the rib cage. Its reverse motor action, which is also important, it posteriorly tilts the pelvis at the lumbosacral joint and flexes the lower trunk relative to the upper trunk. So this is when we do something called a pelvic tilt. This muscle helps in pelvically tilting the pelvic posteriorly. Its innervation is the intercostal nerves at its superior aspects, of course, and then those ventral rami, remember the branch that comes out from the nerve as it leaves the spinal column. This is the ventral rami, which means it's traveling anteriorly, of the levels of T7 to T12, remembering that the nerve that comes out exits out of the intervertebral foramen that we talked about in when we were looking at the spine a week or so ago. So here we are. Here's the external oblique. You can see a fairly large area. This is a lovely diagram because it does show where this anterior position stops and where the aponeurosis is, which we can see here the rectus group lies within. The next is the internal oblique. So this is the lateral 2/3 of the inguinal ligament. This is a ligament that runs basically from the pubic bone to the superior lateral aspects of the pelvic bone. So lateral 2/3 of the inguinal ligament, the iliac crest, and the thoracolumbar fascia. Remembering this is in the back where we find the erectors also attaching to. So this would be sort of the more lateral aspects of the thoracolumbar fascia, to the lower three ribs 10 through 12, and to the abdominal aponeurosis. Its primary actions: it too flexes the trunk of the spinal joints, it laterally flexes the trunk of the spinal joints, and it ipsilaterally rotates the trunk. If you think about its position here, you can see how it's going to ipsilaterally rotate because it's going to bring this part of the muscle towards the hip. Therefore, the left will cause a left turn. Whereas when we look at the external obliques, they're starting here centrally and going up and out to the rib cage. So when this contracts, it pulls, the right one will pull on the right side of the body, thus turning the torso left. The transverse abdominis, again, is the third flat muscle. Its attachments is the lateral 2/3 of that inguinal ligament that I talked about, running from the iliac crest to the pubic bone, the costal cartilages of ribs 7 through 12, the iliac crest, and also the thoracolumbar fascia, to the linea alba of the abdominal aponeurosis. Remember its name, transverse, which means it's running along the transverse plane. Its major role is to compress the abdominal pelvic cavity. Its innervation is the intercostal nerves when we look at those ribs, 7 through 12, and of course the ventral rami, same as the others, T7 to L1. So we see here in the diagram, this is the transversus here. So obviously external oblique is the most superficial, internal is next, and then the transversus is the deepest. And you can see here how it doesn't really have a rotation factor on the torso, but it does hold this area nice and tight for increased pressure in the pelvic or the abdominal area. The vertical one, so we've talked about the three flats. The vertical one is the rectus abdominis. It was the one that you noticed in those pictures when we talk about a six-pack that everyone talks about. It arises from the pubic symphysis and pubic crest of the pubic bone to the xiphoid process and costal cartilages of ribs 5 through 7, or cartilages 5 through 7. Its two primary functions is to flex the trunk at the spinal joints and laterally flexes the trunk at the spinal joints. It does allow for some compression at the abdominal pelvic cavity, and because of the attachment to the costal cartilages, we say it does somewhat depress the rib cage. Not ribs, the rib cage, because obviously there's not really a whole lot of movement at these costal cartilages. It has a reverse motor action as well, similar to what we talked about before, which is a posterior tilt or a pelvic tilt of the pelvis at the lumbosacral joint and flexes the lower trunk relative to the upper trunk. Its innervation is the intercostal nerves because of the 5 through 7, and a little bit higher up in terms of innervation is the ventral rami of T5 to T12. So we see it here in the group. Again, the aponeurosis has been removed, so we can see the redness of the muscle, linea alba here dividing it into right and left side, and we can see that the aponeurosis is lying between the muscles here in the squares, and as I said, has been removed anteriorly so that we can see the muscle. The next one, again, is a muscle that somewhat gets argued about. Some authors say it exists, some doesn't. It's called pyramidalis because it is pyramidal in shape, so somewhat triangular. It is a small triangular muscle. It is absent in 20% of the population that I read about. And it's anterior to the inferior part of rectus abdominis. Anterior to the inferior part of rectus abdominis. Its attachments is the linea alba, centrally, to the anterior surface of the pubis and the anterior pubic ligament. Its main role is just to tense the linea alba, and its innervation is T12, L1, and L2. So we see it here, tiny, tiny little pyramidal shaped muscle. Now the reason I talk about it here and I bring it up is because there is some thoughts that this muscle does present occasionally with trigger points which can cause pain and discomfort in the genital area of both genders. So, if you've got a patient who's come to you who, has not a chief complaint, but through conversation has talked about pain in the genital area. They've been tested for all kinds of things. Physicians can't seem to find anything. This might be a muscle you want to look and see if any of the referral pattern of a trigger point in pyramidalis could result in some of the pain in the genital area that your patient may be expressing. The last muscle is a muscle most often thought of as being part of the lumbar spine, but in fact, because of its placement in relationship to the lumbar vertebra, it is actually considered a posterior abdominal muscle. And its name, quadratus lumborum, tells us that it's basically square and lies in the lumbar area. The reason why people get so confused about where this muscle is in relationship to the lumbar spine is because generally we tend to palpate it from either the posterior aspect, lateral to the lumbar spine, or the posterior lateral position, sort of coming in laterally towards the spinal column, heading medially from starting out laterally, which is my favorite way to palpate it, also my favorite way to treat it. So we can see here how it's square-like and it sits in here from the 12th rib to the iliac crest. We also see it here in behind. This is actually a muscle here called iliopsoas, but the quadratus lumborum muscle is here. So again, because of its placement, it is considered a deep abdominal muscle. So its attachments is the medial half of the inferior border of the 12th rib, medial half of the inferior border of the 12th rib, and the transverse processes of L1, L2, L3, and L4. So it covers a considerable amount of the actual L spine. So you can imagine if this thing's tight, it is going to have a bit of a influence on the mechanical function of the lumbar spine. So it arises from the medial half of the inferior border of the 12th rib and the transverse processes of L1 to L4 to the posteromedial iliac crest and the iliolumbar ligament. Its functions is to elevate the ipsilateral pelvis at the lumbosacral joint and laterally flexes the lower lumbar spine relative to the upper lumbar spine. It can also anteriorly tilt the pelvis at the lumbosacral joint and extend the lower lumbar spine relative to the upper lumbar. So whereas the abdominal muscles do a pelvic tilt, in other words, lifting the anterior aspect of the pubic bone superiorly, this muscle pulls on the posterior aspect of the pelvis, thus causing the pubic bone to travel inferiorly in the anterior aspect. It does have an important reverse motor action. It does laterally flex the trunk at the spinal joints. It also is responsible for depressing the 12th rib at the costal spinal joint when taking a big breath in, and extends the trunk at the spinal joints bilaterally. Now, what's going to be a little bit new for all of you is that its innervation is slightly different in regards to what we've been looking at. The innervation for this muscle actually arises from something called the lumbar plexus, levels T12, L1, L2, and L3. So I'm going to briefly talk a little about what a lumbar plexus is, or what a plexus is. Whenever we see the term plexus, it represents a relationship between a group of nerves that come together and split apart in a particular type of pattern that allows for distribution to particular muscles. So we can see here in this diagram there are two plexuses here. The most famous one is the brachial plexus that arises from the neck and feeds the upper limbs. But we're going to talk a bit about here about the lumbar plexus. You can see that from L1 to L4, sometimes L5, depending on the author, we can see all these nerve roots exiting. So this one's coming from L1, this one's coming from L2, L3, and L4, out that intervertebral foramen. Once they leave, you can see that they start to meet together and have these interrelationships of nerves that come together and get connected all the way through. And we can see how, again, they'll come together, then they'll separate into various muscles. That means then a muscle can have innervation from a number of levels rather than just one. Generally, what happens when we look at a textbook in regards to innervation, and you'll see a number of levels involved in innervation, there may be one or two or three levels that are bolded as compared to the others. That means that upon dissection, the majority of nerve fibers to that muscle, when they trace them back, the majority arise from those bolded levels. So again, here's our plexus, all coming together and then splitting out and breaking apart to reflect and innervate a various number of muscles. We also see it here as well, showing the sacral plexus here, and this is the lumbar plexus here. So we see L1, 2, 3, 4, and 5, where they all come together, and then they're breaking apart with all these branches to innervate various structures throughout. This can include organs as well as muscles. So as I was saying, you can see here the lumbar plexus, the sacral plexus down here, and lumbar, and taking note of all these interconnections that occur between these levels. You'll be talking about this in your neuro class as well as next semester when you're looking at the innervation for the upper limb. So here we can see quadratus lumborum covers a relatively large area, remembering that it just about covers every transverse process of the lumbar spine to the 12th rib. So it's pulling the 12th rib down, flexing the back, and also when we're fixating proximally, it'll raise the iliac crest up. I do spend a bit of time on this muscle because this one is pretty responsible for a lot of back issues, a lot of pain patterns. We're going to learn in the set of slides on trigger points where this refers down into the buttock area and the lateral hip. So we spent a lot of time on this muscle. You'll find that you'll be working on this one quite a bit. Thanks for listening to the slides. There's one more set of slides to come on trigger points, and then the screencasting will be done and we'll be moving forward with the semester.